Welcome to NCLEX-ReviewPro, your trusted e-learning platform for focused, high-yield NCLEX preparation. In this Q&A session, we're diving into respiratory disorders and medications, a core area of the exam where clinical reasoning, prioritization, and safety decisions matter most. Here, every question has a purpose. We'll work through all 7 NCLEX question types, including multiple choice, select all that apply, matrix grids, drop-down close items, ordered response, bow tie questions with clinical interpretation, and highlight the text cue recognition. Each question is designed to challenge how you think, not what you memorize, just like the real exam. This lecture is organized into 3 focused sections. Section 1 covers respiratory disorders, where we'll concentrate on symptom recognition, disease patterns, and early clinical warning signs. Section 2 focuses on procedures and diagnostics, emphasizing escalation, monitoring, and how nurses interpret data to guide safe care. Section 3 moves into respiratory pharmacology, where we connect medications to mechanisms, side effects, labs, and patient safety. Across these sections, we'll break down high-yield NCLEX-style questions, one by one, explaining the logic behind every correct answer and uncovering the traps behind the wrong ones. Each explanation connects exam reasoning to real clinical practice, so you don't just learn facts, you learn to think like a nurse under exam pressure. Stay with me, take notes if you need to, and focus on patterns, not isolated details. Because on the NCLEX, confidence comes from understanding how to reason, not from memorization. This is NCLEX-ReviewPro. Let's begin Section 1, Respiratory Disorders. This first question is testing your ability to recognize key assessment cues that point to an acute respiratory emergency. Before jumping to the answer, take a moment here. Ask yourself, what finding most strongly tells me that air is trapped in the pleural space? We're presented with a 32-year-old client who arrives in the emergency department after sustaining a blunt injury to the chest wall during a motor vehicle collision. There are no open wounds noted on the chest. That detail is important. Now, let's walk through the assessment findings together. The client reports acute chest pain and shortness of breath. The respiratory rate is 28 breaths per minute. Oxygen saturation is 91% on room air. On auscultation, the nurse notes diminished breath sounds on the right side, with unequal chest expansion. On palpation, there is mild subcutaneous emphysema. This is a highlight the text question, so instead of choosing an option, your job is to identify the single most diagnostic finding in the paragraph. As you listen back to those findings, ask yourself, which one most clearly confirms the suspected condition? The correct finding to highlight is diminished breath sounds on the right side. Here's why this is correct. A closed pneumothorax caused by blunt trauma allows air to enter the pleural space without an open chest wound. As air accumulates, the affected lung cannot fully expand. That leads directly to diminished or absent breath sounds on the affected side. This is the most specific and clinically meaningful finding pointing to pneumothorax. Other findings support respiratory compromise, but they are not as definitive. Tachypnea and low oxygen saturation tell you the client is struggling to oxygenate, but they do not identify the cause. Subcutaneous emphysema can occur with pneumothorax, but it is a secondary clue. And remember, a sucking sound would indicate an open pneumothorax, which is ruled out here. A low respiratory rate would not fit acute distress. A barrel chest is a chronic finding associated with COPD, not acute trauma. NCLEX alert. Anytime you see blunt chest trauma paired with unilateral diminished breath sounds, pneumothorax should be at the top of your differential. That cue alone should prompt immediate action. Key takeaway. In respiratory questions, listen for what's missing on one side of the chest. Unequal breath sounds matter more than general symptoms. Keep that framework in mind as we move on to the next question. Let's move to our second question. This question is testing your ability to connect mechanism of injury with expected respiratory assessment findings. Before looking at the options, pause and think. When a rib is fractured, what is the body trying to protect? We're given a client admitted after a fall from a ladder. Imaging confirms a fractured rib on the left side. During the respiratory assessment, the nurse notices that the client is guarding the chest and limiting thoracic movement. Those are important cues. They tell you the client is trying to reduce pain by minimizing chest expansion. Now let's walk through the answer options. Option A, slow, deep respirations. That doesn't fit. Deep breathing increases rib movement and would worsen pain, so clients actively avoid it. Option B, rapid, deep respirations. Again, the depth is the problem. With rib fractures, respirations may become shallow, not deep, because inspiration is painful. Option C, paradoxical chest wall movement. This is a key distractor. Paradoxical movement occurs with flail chest, which requires multiple rib fractures, creating a floating segment, not a single rib fracture. Option D, pain that worsens with inspiration. This is the correct answer. Here's why this fits best. Rib fractures cause localized pain and tenderness at the injury site. That pain becomes worse with inspiration because the ribs move outward during breathing. As a result, clients often splint the chest, take shallow breaths, and limit thoracic movement to reduce discomfort. This pain-limited breathing pattern is the classic presentation of a rib fracture. NCLEX alert. If a question mentions rib fracture, expect pain with inspiration and shallow breathing. If you see paradoxical chest movement, stop. That points to flail chest, not a simple fracture. Key takeaway. With rib fractures, pain drives the assessment findings. The nurse should always anticipate restricted chest movement and inspiratory pain. Keep that distinction clear as we move into the next respiratory scenario. Question 3. This is a highlight the text question type, and it's designed to test your ability to recognize a defining clinical cue for a failed chest from a severe chest wall injury. As you listen to the assessment findings, focus on identifying the one finding that is unique to this condition. We're told a client is brought to the emergency department after a high-speed motor vehicle collision. Imaging reveals multiple adjacent rib fractures on the left side. That detail is important. Multiple adjacent fractures should already raise concern for chest wall instability. Now let's walk through the nurse's documented assessment findings together. The client is tachypnic and reports severe chest pain. On inspection of the chest wall, the nurse observes that a segment of the left thorax moves inward during inspiration and bulges outward during expiration. Breath sounds are present bilaterally. This is a highlight the text question. Your task is not to diagnose generally, but to identify the single most distinctive finding of a flail chest. As you review those findings, listen for what stands out as unique. The correct finding to highlight is moves inward during inspiration and bulges outward during expiration, demonstrating paradoxical chest movement. Here's why this finding is so critical. In flail chest, multiple rib fractures create a floating segment of the chest wall that is no longer synchronized with normal thoracic movement. During inspiration, when the chest should expand outward, the flail segment collapses inward. During expiration, when the chest should move inward, the segment pushes outward. This opposite movement pattern is called paradoxical chest movement, and it is the hallmark finding of flail chest. Other findings in the scenario, such as tachypnea, chest pain, or even the presence of bilateral breath sounds, may occur with many respiratory injuries. They support distress, but they do not define the condition. Paradoxical movement does. NCLEX alert. Anytime you see multiple rib fractures paired with inward movement on inspiration and outward movement on expiration, flail chest should immediately come to mind. That pattern indicates impaired ventilation and a high risk of respiratory failure. Key takeaway. Flail chest is identified by how the chest wall moves, not just by pain or breathing rate. When movement is paradoxical, ventilation is compromised. Keep that cue recognition mindset as we move to the next question. Question 4. This is a matrix/grid question type, and it's designed to test your ability to classify assessment findings based on COPD pathophysiology during an acute exacerbation. Before filling in the grid, pause here. Matrix questions are not about guessing. They are about grouping findings into what fits and what does not. So the key question is, what does COPD normally do to the lungs and gas exchange? We're given a client hospitalized with an acute exacerbation of chronic obstructive pulmonary disease. The nurse is reviewing assessment findings, diagnostic results, and activity tolerance. Let's walk through each finding one at a time and decide whether it is expected or not expected. First finding, hyperinflated chest on chest X-ray. This is expected. COPD causes air trapping and loss of elastic recoil, which leads to lung hyperinflation. Over time, this results in an enlarged, hyperinflated chest appearance on imaging. Second finding, decreased oxygen saturation with mild activity. This is also expected. During an exacerbation, gas exchange is impaired. Even minimal exertion can worsen hypoxemia, causing oxygen saturation to drop with activity. Third finding, low arterial PaCO2 level. This is not expected. In COPD, ventilation is impaired. Carbon dioxide is retained, leading to elevated PaCO2, also known as hypercapnia. A low PaCO2 would suggest hyperventilation, which does not match COPD physiology. Fourth finding, increased vital capacity on pulmonary function testing. This is not expected. COPD is an obstructive disease. Airflow limitation and air trapping result in a decreased vital capacity, not an increased one. Fifth finding, flattened diaphragm on chest X-ray. This finding is expected. Chronic hyperinflation pushes the diaphragm downward, causing it to flatten. A flattened diaphragm is a classic radiographic finding in COPD. NCLEX alert. When you see COPD, anchor on these core patterns: air trapping, hyperinflation, hypoxemia, hypercapnia, reduced lung volumes. If a finding contradicts one of those, it usually belongs in the not expected column. Key takeaway: matrix questions reward pattern recognition. If you understand how COPD changes lung structure and gas exchange, the grid becomes straightforward. Keep those physiologic patterns in mind as we move on to the next respiratory disorder question. Question 5. The nurse is instructing a hospitalized client with a diagnosis of emphysema about measures that will enhance the effectiveness of breathing during dyspneic periods. Which position would the nurse instruct the client to assume? Before we look at the options, pause for a moment. This question is asking you to think about which position improves ventilation when a client with emphysema is short of breath. Now let's read the answer options. Option 1, sitting up in bed. Option 2, side lying in bed. Option 3, sitting in a recliner chair. Option 4, sitting up and leaning on an overbed table. The correct answer is option 4, sitting up and leaning on an overbed table. Here's why this is the best choice. Clients with emphysema benefit from positions that optimize diaphragmatic movement and allow the accessory muscles of respiration to work more effectively. Leaning forward while supporting the arms, often called the tripod position, stabilizes the upper body. This reduces the work of breathing and allows the diaphragm to descend more effectively during inspiration. The other positions may provide comfort, but they do not offer the same mechanical advantage during acute dyspnea. NCLEX alert. Anytime you see emphysema and shortness of breath, think tripod positioning. This is a classic nursing intervention and a frequent exam favorite. The key takeaways are: positioning can significantly improve ventilation in emphysema. Forward-leaning, arm-supported positions reduce respiratory effort and improve gas exchange. Let's move on to the next question. Question 6. A client arrives in the emergency department with sudden onset respiratory distress. The client appears anxious and restless. Vital signs reveal tachycardia and an increased respiratory rate. The nurse suspects a pulmonary embolism based on the client's presentation. Which symptom is most commonly reported first in a client experiencing a pulmonary embolism? Before we look at the options, pause here. This question is testing early recognition. The key word to anchor on is first. Now, let's read the answer options. Option A, a sudden flush sensation. Option B, chills accompanied by fever. Option C, sudden onset chest pain. Option D, shortness of breath that occurs only with deep inspiration. The correct answer is option C, sudden onset chest pain. Here's why this fits best. In a pulmonary embolism, blood flow to part of the lung is suddenly blocked. That abrupt obstruction causes acute chest pain, often pleuritic in nature, and it is the most commonly reported initial symptom. Dyspnea usually follows shortly after and is often accompanied by tachypnea and anxiety, but it is not always the very first symptom the client reports. Option A suggests a vasomotor or allergic response, not an embolic event. Option B points toward infection, which does not match the sudden presentation. Option D is a common trap. Dyspnea with a pulmonary embolism is not limited to deep breathing, and it is typically not the first complaint. NCLEX alert. Anytime you see sudden chest pain plus anxiety, tachycardia, and respiratory distress, pulmonary embolism should be high on your differential. When the question asks for the first or most common symptom, choose the classic presentation, not a secondary effect. The key takeaways are these. Pulmonary embolism often begins with sudden chest pain. Dyspnea and tachypnea usually follow, not lead. Sudden respiratory symptoms without fever should raise concern for embolic causes. Let's move on to the next question. Question 7. A client with multiple traumatic injuries is admitted to the intensive care unit following a motor vehicle collision. Over the next several hours, the nurse closely monitors the client for signs of developing acute respiratory distress syndrome, or ARDS. Which assessment finding would the nurse identify as the earliest indicator of ARDS? Before we look at the options, pause here. This question is testing early identification. The key word is earliest. Now, let's read the answer options. Option A, bilateral wheezing. Option B, inspiratory crackles. Option C, intercostal retractions. Option D, increased respiratory rate. The correct answer is option D, increased respiratory rate. Here's why this is correct. ARDS begins with progressive impairment in gas exchange following a major insult, such as trauma, sepsis, or shock. Before you hear abnormal breath sounds or see visible retractions, the body first compensates by breathing faster. Tachypnea is often the earliest detectable sign, and it may appear within hours after the initial injury. As ARDS progresses, clients develop worsening dyspnea, air hunger, use of accessory muscles, cyanosis, and later, crackles or diffuse breath sounds. Let's briefly look at why the other options are incorrect. Bilateral wheezing is not an early finding in ARDS and is more commonly associated with obstructive airway disease. Inspiratory crackles can occur, but they typically appear later as alveoli become filled with fluid. Intercostal retractions signal increased work of breathing and respiratory fatigue, which also occur after tachypnea. NCLEX alert. When the question asks for the earliest sign of respiratory failure, think rate before sounds. An abnormal respiratory rate is almost always the first clue that deterioration is beginning. The key takeaways are these. In ARDS, tachypnea is the earliest indicator of worsening gas exchange. Visible distress and abnormal lung sounds come later. Early recognition depends on trending respiratory rate, not waiting for dramatic findings. Keep this early warning framework in mind as we move into the next question. Question 8. A client with pulmonary sarcoidosis is preparing for discharge. The nurse reinforces teaching about symptoms that may indicate early disease exacerbation and require prompt follow-up. Which symptoms should the nurse instruct the client to report immediately as an early sign of exacerbation? Before we look at the options, pause here. This question is testing early recognition, not late or systemic effects. Focus on what changes first when pulmonary function begins to worsen. Now let's read the answer options. Option A, fever. Option B, fatigue. Option C, weight loss. Option D, shortness of breath. The correct answer is option D, shortness of breath. Here's why this is the best choice. Pulmonary sarcoidosis primarily affects the lungs. Early exacerbation leads to impaired ventilation, which presents first as dyspnea, often accompanied by a dry cough. Shortness of breath reflects a direct change in respiratory function and requires prompt evaluation. Fever and weight loss are systemic symptoms that usually appear later in the disease course. Fatigue may occur, but it is often secondary to worsening respiratory impairment, not an early warning sign on its own. NCLEX alert. When a question asks for an early sign of pulmonary disease exacerbation, prioritize symptoms that reflect ventilation or oxygenation changes, not general constitutional complaints. The key takeaways are these. Pulmonary sarcoidosis worsens in the lungs first. Dyspnea is an early and clinically meaningful warning sign. Systemic symptoms tend to follow, not lead. Keep that early recognition framework in mind as we continue to the next question. Question 9. While obtaining the occupational history of a client diagnosed with silicosis, the nurse focuses on workplace safety measures used during exposure to silica-containing dust. Which protective item should the nurse specifically ask the client about using during periods of exposure? Before we look at the options, pause here. This question is testing prevention, not treatment. Ask yourself, how does silica actually enter the body? Now let's read the answer options. Option A, mask. Option B, gown. Option C, gloves. Option D, eye protection. The correct answer is option A, mask. Here's why this is correct. Silicosis develops from the chronic inhalation of crystalline silica particles. Because the exposure route is respiratory, the most effective preventive strategy focuses on reducing inhalation. A properly fitted mask or respirator limits the amount of silica dust that reaches the lungs, helping prevent long-term restrictive lung disease. Protective clothing, gloves, and eye protection may be useful for general workplace safety, but they do not prevent inhalation of airborne particles, which is the primary cause of silicosis. NCLEX alert. When the question is about occupational lung disease, always identify how the hazard enters the body. If the exposure is inhaled, respiratory protection is the priority. The key takeaways are these. Silicosis is caused by inhaling silica dust, not skin or eye contact. Prevention focuses on limiting inhalation exposure. Respiratory protection is the most critical safety measure. Keep that exposure-based thinking in mind as we move on to the next question. Question 10. A client with acquired immunodeficiency syndrome, or AIDS, presents with several weeks of fever, fatigue, and worsening respiratory symptoms. The healthcare provider suspects histoplasmosis, an opportunistic fungal infection. Which findings should the nurse most expect when assessing this client? Before we look at the options, pause here. This question is testing pattern recognition. Focus on the combination of immunocompromised status and opportunistic infection. Now let's read the answer options. Option A, dyspnea. Option B, headache. Option C, weight gain. Option D, hypothermia. The correct answer is option A, dyspnea. Here's why this fits best. Histoplasmosis is a fungal infection that begins in the lungs, especially in clients who are immunocompromised, such as those with AIDS. Because the infection initially involves the respiratory system, the most expected and early finding is difficulty with ventilation. Dyspnea reflects impaired oxygen exchange and is the hallmark respiratory symptom in this condition. Headache is not a primary manifestation of a pulmonary fungal infection. Weight gain is inconsistent with chronic infection, which typically causes weight loss. Hypothermia is also incorrect because infections are associated with fever, not low body temperature. NCLEX alert. Anytime you see AIDS paired with a fungal infection, think lungs first. And when the question asks for the most expected finding, choose the classic respiratory presentation, not a late complication or unrelated symptom. The key takeaways are these. Opportunistic fungal infections in AIDS often begin in the lungs. Dyspnea is an early and expected finding. When immunocompromised and respiratory symptoms appear together, prioritize impaired oxygenation. Keep this pattern in mind as we move to the next question. Question 11. A community health nurse is teaching participants about recognizing tuberculosis, or TB, in the community. The nurse explains that TB should be suspected when certain signs and symptoms are present. Which findings are consistent with tuberculosis? Select all that apply. Before we read the options, pause here. This is a select all that apply question. That means each option must be evaluated independently. There is no partial credit on the NCLEX. Now let's go through the answer choices one by one. Dyspnea, headache, night sweats, bloody productive cough, persistent cough with mucoid sputum. The correct answers are dyspnea, night sweats, bloody productive cough, persistent cough with mucoid sputum. Let's break down the reasoning. Tuberculosis is a chronic infectious disease that primarily affects the lungs. Because of that, the hallmark findings are persistent respiratory symptoms, not sudden or isolated complaints. A long-standing cough with mucoid sputum is classic. As the disease progresses, hemoptysis, or bloody sputum, may occur. Dyspnea reflects impaired ventilation and gas exchange. Night sweats are a common systemic manifestation of chronic infection. Now let's address the option that does not belong. Headache is not a characteristic finding of pulmonary tuberculosis and is not primarily respiratory in nature. While TB can disseminate, headache is not a classic or expected community-level presentation. NCLEX alert. When you see TB, think chronic, not acute. A cough that lasts weeks, sputum production, night sweats, and bloody sputum should immediately raise concern. Bloody sputum is a red flag on the exam. Never ignore it. The key takeaways are these. Tuberculosis presents with chronic respiratory symptoms plus systemic signs. Persistent cough, dyspnea, night sweats, and hemoptysis are classic findings. Non-respiratory symptoms like headache should be eliminated unless the question clearly points to dissemination. Let's continue to the next question. Question 12. A client diagnosed with pulmonary tuberculosis has been receiving antitubercular medication therapy for 2 weeks. The nurse evaluates the client's understanding of treatment expectations and disease transmission before discharge. Which client statement indicates correct understanding of the teaching? Before we read the options, pause here. This question is testing whether the client understands the difference between treatment duration and infectivity. Now let's read the answer options. Option A. I need to continue medication therapy for 1 month. Option B. I can't shop at the mall for the next 6 months. Option C. I can return to work if a sputum culture comes back negative. Option D. I won't be contagious after 2 to 3 weeks of medication therapy. The correct answer is option D. I won't be contagious after 2 to 3 weeks of medication therapy. Here's why this statement shows correct understanding. Tuberculosis treatment lasts for many months, often 6 months or longer. However, with consistent and correct medication use, most clients become non-contagious after about 2 to 3 weeks. This is a key distinction the NCLEX tests repeatedly. Option A is incorrect because 1 month of therapy is not sufficient. Option B reflects unnecessary long-term restriction and fear. Option C is a common trap. Returning to work requires 3 negative sputum cultures, not just 1. NCLEX alert. Always separate these 2 concepts in TB questions. Treatment duration is long, the contagious period is relatively short. When the question asks about understanding, look for the statement that reflects accurate teaching, not excessive restriction or misinformation. The key takeaways are these. Tuberculosis requires long-term medication therapy. Most clients are no longer contagious after 2 to 3 weeks of proper treatment. Returning to work depends on sputum culture clearance, not symptoms alone. Let's move on to the next question. Question 13. A client who is HIV positive undergoes a tuberculin skin test as part of routine screening. When the nurse reads the test 48 to 72 hours later, a 7 mm area of induration is noted. Complete the statement by selecting the correct option from the drop-down menu. In a client with HIV infection, a tuberculin skin test result of 7 mm of induration is interpreted as blank. Pause here before choosing. This is a drop-down close question, so accuracy matters. The key concept being tested is how immune status changes interpretation. Now, think carefully before selecting. The correct selection is positive. Here's why this interpretation is correct. Clients with HIV are immunocompromised, so the threshold for a positive tuberculin skin test is lower than in the general population. In clients who are HIV positive or otherwise immunosuppressed, an induration of 5 millimeters or greater is considered positive. For healthy adults without risk factors, the cutoff is 10 millimeters. In this scenario, the induration measures 7 millimeters, which clearly meets the criteria for a positive result in a client with HIV. This means the test is neither negative nor inconclusive, and repeat testing is not required. NCLEX alert. Anytime a question includes HIV or immunosuppression, you must automatically lower the TB cutoff. A smaller number does not mean a weaker result. It means the immune system responds differently. Do not apply the 10 millimeter rule to everyone. The key takeaways are these. Tuberculosis screening cutoffs change based on immune status. In HIV-positive clients, 5 millimeters or more is positive. If induration is present and meets the cutoff, the result is positive. No repeat testing needed. Let's continue to the next question. Question 14. A 49-year-old client is admitted with 6 weeks of progressive symptoms, including a persistent cough with occasional blood-streaked sputum, night sweats, fatigue, and unintentional weight loss. The client reports that a coworker was recently treated for a lung infection. The client has a 20-pack-year smoking history and no known chronic lung disease. Now let's review the diagnostic data provided. Vital signs show a temperature of 38.2 degrees Celsius, a respiratory rate of 24 per minute, oxygen saturation of 92% on room air, and a heart rate of 112 per minute. Laboratory findings reveal a mildly elevated white blood cell count, low hemoglobin, and elevated inflammatory markers. Imaging demonstrates a right upper lobe cavitary lesion with hilar lymphadenopathy. The radiology note states these findings could represent tuberculosis, a fungal infection, or malignancy. TB screening shows a 12 millimeter induration on tuberculin skin testing. Respiratory microbiology reveals a positive acid-fast bacilli smear, a positive TB PCR, and a sputum culture growing Mycobacterium tuberculosis complex. Drug susceptibility is pending. This is a bow tie question. Bow tie questions test 3 things at once. First, can you identify the strongest evidence? Second, can you interpret what that evidence means? And third, can you choose the most appropriate nursing actions? Let's start with the left side. Which 2 findings most strongly support the diagnosis of active pulmonary tuberculosis rather than a mimic? Pause here. Imaging and screening tests may suggest TB, but they do not confirm it. The question is asking for organism-level evidence. The correct left side selections are NAT-T, or TB-PCR, detected, and sputum culture showing growth of Mycobacterium tuberculosis complex. Here's why. A TB-PCR provides rapid molecular evidence of tuberculosis DNA. A positive sputum culture confirms the actual presence and growth of the organism. CT findings and TST results support suspicion, but they can also be seen with fungal infections or malignancy. They are not definitive. Now look at the center, which is given. Definitive diagnosis of active pulmonary tuberculosis. Because we have organism confirmation, the diagnosis is no longer suspected. It is confirmed. Now move to the right side. Which 2 nursing actions are most appropriate right now? Think transmission. Think public safety. Think priority. The correct right side actions are: initiate airborne isolation precautions immediately using a negative pressure room if available, and notify infection control or public health per facility policy. Here's the reasoning. Active pulmonary tuberculosis is an airborne disease. Once confirmed or strongly supported by organism evidence, airborne isolation is mandatory. Public health notification is also critical because TB requires contact tracing and community monitoring. Starting incentive spirometry does not address transmission risk. Stopping isolation because the client is afebrile is unsafe and incorrect. Afebrile does not mean non-infectious. NCLEX alert. This is a high-yield rule. Imaging plus TST equals suspicion, PCR or culture equals confirmation, and confirmation always triggers airborne precautions and public health action. The key takeaways are these. Tuberculosis cannot be confirmed by imaging or skin testing alone. Organism-level evidence establishes the diagnosis. Once TB is confirmed or strongly supported, airborne isolation and infection control notification are immediate priorities. Keep this evidence to action framework in mind as we move forward. Question 15. A client is being discharged after treatment initiation for pulmonary tuberculosis. The nurse prepares a home care instruction list that focuses on recovery, infection control, and follow-up monitoring. Which instructions should the nurse include? Select all that apply. Before we go through the options, pause here. This is a select all that apply question. Each option must be evaluated on its own clinical accuracy. Also notice the focus of the question: home care, recovery, infection control, follow-up. Keep those priorities in mind as we review the options. Now let's go through them one by one. Resume activities gradually as tolerated. This is correct. Clients recovering from tuberculosis often experience fatigue and deconditioning. Gradual return to activity supports recovery without overexertion. Avoid contact with all people except family for at least 6 months. This is incorrect. Clients are usually no longer contagious after 2 to 3 weeks of effective therapy, not 6 months. This option reflects unnecessary restriction rather than evidence-based teaching. Obtain sputum cultures every 2 to 4 weeks after starting therapy. This is correct. Ongoing sputum monitoring is essential to evaluate treatment response and determine infectivity status. Respiratory isolation at home is not necessary because household members have already been exposed. This is correct. By the time TB is diagnosed, close household contacts have typically already been exposed. Strict home isolation is not required, but education is still important. Cover the mouth and nose when coughing or sneezing, and discard used tissues in sealed plastic bags. This is correct. Cough etiquette and proper disposal of secretions are critical infection control measures during recovery. When one sputum culture is negative, you are no longer infectious and can return to work. This is incorrect. Return to work typically requires 3 negative sputum cultures, not 1. This option is a classic NCLEX trap. The correct answers are: resume activities gradually as tolerated. Obtain sputum cultures every 2 to 4 weeks after starting therapy. Respiratory isolation at home is not necessary because household members have already been exposed. Cover the mouth and nose when coughing or sneezing, and discard used tissues in sealed plastic bags. NCLEX alert. Tuberculosis teaching is often tested using over-restriction traps. 6 months of isolation and 1 negative culture are both incorrect. Look for balanced, realistic, and evidence-based instructions. The key takeaways are these. TB home care teaching focuses on recovery, infection control, and follow-up monitoring. Most clients are no longer contagious after a few weeks of effective therapy. Returning to work requires confirmed sputum clearance, not assumptions. That completes this set of respiratory disorder questions. We're now moving into Section 2, Respiratory Procedures and Diagnostics. This section focuses on how nurses interpret findings, respond to complications, and prioritize actions during and after respiratory procedures. Here, the NCLEX is not testing memorization. It is testing clinical judgment. You'll be asked to decide what is expected versus dangerous, when to assess, when to intervene, when to notify the provider, and when to document. Pay close attention to orders. They change priority. And remember, in respiratory care, airway and breathing always come before paperwork. Let's begin with our first question in this section. Question 16. A client returns to the unit after undergoing a bronchoscopy with biopsy. The post-procedure orders include albuterol nebulizer as needed for bronchospasm and oxygen via nasal cannula as needed to maintain oxygen saturation greater than or equal to 94%. During the first hour of monitoring, the nurse notes the following: heart rate 108 per minute, respiratory rate 26 per minute, oxygen saturation 90% on room air. On assessment, the nurse notes audible wheezing, increased work of breathing, chest tightness, blood-streaked sputum, and a dry, non-productive cough. Place the nurse's actions in the correct order of priority, from first to last. Pause here. This is an ordered response question. That means priority matters more than sequence of appearance. Also notice something very important. There is a PRN bronchodilator order already in place. That changes what you are allowed to do. Let's walk through the given actions briefly. Assess, document, administer, prepare, notify. Now let's place them in order. The first action is assess breath sounds and airway patency. You must confirm the problem. Wheezing, increased work of breathing, and a drop in oxygen saturation suggest bronchospasm, but assessment always comes first. The second action is prepare emergency airway equipment and oxygen delivery setup. Before treating, the nurse prepares for potential rapid deterioration. This is within nursing scope and reflects safe practice. The third action is administer the prescribed PRN bronchodilator treatment. Because the PRN order already exists, the nurse is authorized to treat immediately. Delaying treatment to call the provider would be incorrect. The fourth action is notify the healthcare provider of the client's response and suspected bronchospasm. This allows the provider to evaluate next steps once the immediate airway issue has been addressed. A correct report sounds like this. The patient had wheezing and decreased oxygen saturation. I initiated oxygen and administered PRN albuterol. Here is the current status. The final action is document assessment findings, interventions, and client response. Documentation always comes after stabilization, never before. Let's clarify an important point. Blood-streaked sputum and a dry cough are expected findings after a bronchoscopy with biopsy. They do not require intervention. Wheezing, increased work of breathing, and low oxygen saturation do. NCLEX alert. PRN orders change priority. If a PRN exists, treat before calling. If no PRN exists, call before treating. And never document before the airway is stable. The key takeaways are these. Bronchospasm after bronchoscopy is an airway emergency. Assessment comes first, then preparation, then treatment when a PRN order is present. Provider notification follows intervention. Documentation is always last. Keep this PRN-driven priority framework in mind as we continue through the procedures and diagnostics section. Question 17. A client is 6 hours post-operative following a thoracotomy with chest tube placement for a traumatic pneumothorax. The nurse is performing routine assessment of the chest tube drainage system. Let's carefully walk through the findings. Vital signs show a heart rate of 122 per minute, a respiratory rate of 30 per minute, blood pressure 88/54, and an oxygen saturation of 89% on 2 liters nasal cannula. On respiratory assessment, the nurse notes tracheal deviation to the right, decreased breath sounds on the left, and increasing dyspnea and anxiety. When inspecting the chest tube system, there is continuous bubbling in the water seal chamber. The drainage system is below chest level, and the connections appear intact. This is a bow tie question. Bow tie questions require you to connect 3 things: what is causing the problem, what that problem means physiologically, and what the nurse must do right now. The interpretation in the center is already given: developing tension pneumothorax due to ineffective chest tube function. So your job is to support that interpretation and act on it. Let's start on the left side. Which findings most strongly indicate the cause of the client's deterioration? Select 2. Pause here. Think device failure. Think air going where it should not. The correct left side selections are air leak resulting in loss of water seal and chest tube malfunction allowing air to re-enter the pleural space. Here's the logic. Continuous bubbling in the water seal chamber means air is moving into the system, not just out of the chest. That indicates a persistent air leak. When air re-enters the pleural space and cannot escape, pressure builds. That pressure shifts the mediastinum and compromises both ventilation and circulation. Postoperative pain and expected drainage do not explain tracheal deviation, hypotension, and hypoxia. Now look at the right side. Which nursing actions should be performed immediately? Select 2. This is a true emergency. The correct right side actions are: apply an occlusive petroleum dressing to prevent additional air entry, and notify the healthcare provider and prepare for emergency intervention. Here's why. The priority is to stop more air from entering the pleural space and to escalate care immediately. Applying an occlusive dressing helps limit further air leakage while definitive management is arranged. This situation requires urgent provider involvement because tension pneumothorax is life-threatening. Increasing oxygen alone delays treatment. Milking or stripping chest tube tubing is outdated, unsafe, and contraindicated. NCLEX alert. Chest tube questions are heavy on red flags. Continuous bubbling plus worsening vital signs is never normal. Tracheal deviation, hypotension, and hypoxia point to tension pneumothorax. When that pattern appears, reassessment is not enough. The key takeaways are these. Continuous bubbling signals an air leak. Tracheal deviation and shock indicate tension physiology. Nursing priorities are to stop air entry and escalate care immediately. Keep this cause-to-action framework in mind as we move to the next procedures and diagnostics question. Question 18. A nurse is assigned to provide complete hygiene care to an immobilized client with active pulmonary tuberculosis. The planned care includes repositioning the client, assisting with a bed bath, and changing bed linens. The nurse anticipates close, prolonged contact with the client. Which set of personal protective equipment should the nurse wear while performing this care? Before reading the options, pause here. This question is testing infection control decision-making. You must match the route of transmission to the type of care being performed. Now let's read the answer options. Option A, surgical mask and gloves. Option B, individually fitted particulate respirator, gown, and gloves. Option C, particulate respirator and protective eyewear. Option D, surgical mask, gown, and protective eyewear. The correct answer is option B, individually fitted particulate respirator, gown, and gloves. Here's why this is correct. Active pulmonary tuberculosis requires airborne precautions. That means the nurse must wear an N95 or equivalent particulate respirator, not a surgical mask. Because the nurse is performing hands-on care, including repositioning and bathing, gloves are required under standard precautions. A gown is also necessary because close contact increases the risk of clothing contamination during movement and linen changes. Now let's quickly review why the other options are incorrect. A surgical mask does not protect against airborne particles. Eye protection is not routinely required unless splashing or spraying is anticipated, which is not indicated here. NCLEX alert. Always match PPE to how the organism spreads, not to habit or convenience. Tuberculosis is airborne. Airborne equals N95, not surgical mask. And remember, standard precautions never go away. The key takeaways are these. Tuberculosis requires airborne precautions. Hands-on care adds gloves and a gown. Correct PPE protects the nurse and prevents transmission. Let's continue to the next procedure and diagnostics question. Question 19. A client is brought to the emergency department after being found unconscious in a closed garage with a running vehicle. The client is now awake but complains of headache, dizziness, and nausea. Let's review the assessment data exactly as presented. Skin color is pink and warm. Respiratory rate is 18 per minute. Heart rate is 104 per minute. Blood pressure is 128/76. Monitoring data shows a pulse oximetry reading of 99% on room air. Arterial blood gas results show a PaO2 of 92 millimeters of mercury, a PaCO2 of 40, and a pH of 7.40. This is a matrix/grid question. Matrix questions test whether you can classify statements as accurate or inaccurate based on physiology, not appearances. Now pause and look at the symptoms. Headache, dizziness, and nausea are not random complaints. These are classic early signs of cerebral hypoxia. On the NCLEX, when you see a garage exposure plus neurologic symptoms like headache, always think carbon monoxide, even if the oxygen numbers look normal. Let's go through each statement. Pulse oximetry accurately reflects tissue oxygenation in this client. This statement is inaccurate. Pulse oximetry cannot tell the difference between oxygen-bound hemoglobin and carbon monoxide-bound hemoglobin. It reads both as if oxygen were present. Normal oxygen saturation rules out hypoxia in this client. This is also inaccurate. A normal SpO2 does not rule out hypoxia in carbon monoxide poisoning. Tissues can be severely hypoxic even when the saturation appears normal. Pulse oximetry cannot distinguish oxyhemoglobin from carboxyhemoglobin. This statement is accurate. This is the key limitation being tested in this question. Arterial blood gas oxygen values may appear normal despite cellular hypoxia. This is accurate. PaO2 reflects oxygen dissolved in plasma, not oxygen delivery to tissues. It can remain normal while hemoglobin is functionally unusable. Co-oximetry is the most reliable test to confirm suspected exposure. This statement is accurate. Co-oximetry directly measures different hemoglobin species, including carboxyhemoglobin, making it the gold standard for diagnosis. NCLEX alert. Never trust pulse oximetry readings in fire or garage exposure scenarios. Pink skin, normal SpO2, and normal PaO2 can all be misleading in carbon monoxide poisoning. If the story suggests carbon monoxide, rely on co-oximetry, not surface numbers. The key takeaways are these. Pulse oximetry measures saturation, not oxygen delivery. Carbon monoxide falsely elevates SpO2 readings. Normal oxygen values do not rule out hypoxia. Co-oximetry is essential when carbon monoxide exposure is suspected. Keep this diagnostic limitation in mind as we move forward. Question 20. A client undergoes a diagnostic thoracentesis to remove pleural fluid from the right lung. 30 minutes after returning to the unit, the nurse performs a focused assessment. The nurse notes the following: new onset shortness of breath, diminished breath sounds on the right side, a respiratory rate of 28 breaths per minute, oxygen saturation of 91% on room air, and complaints of chest tightness. Pause here. This question is testing your ability to recognize a post-procedure complication and prioritize nursing actions. Before thinking about the order, ask yourself one key question. What is the most dangerous complication after a thoracentesis? Now, let's look at the actions you are asked to prioritize. This is an ordered response question. Remember, ordered response is about priority, not convenience, not what feels polite, and not what finishes the task fastest. Think assessment first, then stabilization, then escalation, then confirmation. Documentation is always last. The correct order begins with assessing breath sounds and vital signs. This must come first. The client is showing signs of acute respiratory compromise, and assessment confirms the severity and progression of the problem. Next, the nurse should administer supplemental oxygen per order. Oxygen supports gas exchange immediately and is within the nurse's scope. Do not delay oxygen when saturation is dropping. Third, the nurse should notify the healthcare provider of a suspected complication. At this point, the nurse has objective findings consistent with a pneumothorax following thoracentesis. This requires prompt medical intervention. Next, the nurse should prepare the client for a chest X-ray. The X-ray confirms the diagnosis, but notice the sequencing. Diagnostics never come before stabilization and provider notification when the client is unstable. Finally, the nurse documents assessment findings, interventions, and the client's response. Documentation always comes after care is delivered and the situation is escalated. Here's why this sequence matters. Thoracentesis places the client at risk for pneumothorax due to potential lung puncture. Sudden dyspnea, unilateral diminished breath sounds, tachypnea, and decreased oxygen saturation are early red flags. On the NCLEX, new respiratory distress after a lung procedure is never normal. You do not watch and wait. You assess, support oxygenation, escalate care, and confirm the diagnosis. NCLEX alert. Assessment always comes before diagnostics. Stabilization always comes before documentation. And post-procedure respiratory changes are treated as complications until proven otherwise. The key takeaway is this. Anytime fluid or air is removed from the pleural space, the risk of lung collapse exists. Recognize it early, act quickly, and follow priority-based nursing logic. Keep that framework in mind as we move forward to the next procedures and diagnostics question. Question 21. This is an ordered response escalation question focused on early recognition and nursing response in acute respiratory distress syndrome, or ARDS. Take a moment before rushing in. ARDS does not begin loudly. It begins subtly. Now let's walk through the scenario. A client is admitted to the intensive care unit following multiple traumatic injuries from a motor vehicle collision. The client required aggressive fluid resuscitation and blood transfusions. Over the next several hours, the nurse notes, increasing restlessness and anxiety, oxygen saturation trending downward despite supplemental oxygen, initially clear breath sounds bilaterally. Pause here. This is the classic setup for early ARDS. The question is not asking what ARDS looks like at its worst. It is testing whether you can recognize how it starts and how nurses should escalate care step by step. Part A. Ordering the assessment findings. You are asked to place the findings in the order they are most likely to occur as ARDS begins and progresses. Remember this rule for the NCLEX. Rate changes first. Subjective distress next. Visible effort after that. Auscultation changes come last. With that framework, the correct order is: first, increased respiratory rate. Tachypnea is the earliest and most reliable sign of worsening gas exchange. This often appears hours before lung sounds change. Second, development of dyspnea and air hunger. As oxygenation worsens, the client becomes aware of breathing difficulty and anxiety increases. Third, onset of intercostal retractions and accessory muscle use. This reflects increased work of breathing and impending fatigue. Fourth, appearance of inspiratory crackles. Crackles are a late finding, caused by alveolar flooding and reduced lung compliance. On the NCLEX, clear lungs do not rule out ARDS early. Part B. Ordering the nursing interventions. Now the question shifts. This part tests nursing escalation, not diagnosis. Ask yourself, what should the nurse do as deterioration begins, not after failure occurs? The correct order is: first, increase frequency of respiratory and oxygen saturation monitoring. Early ARDS can worsen rapidly. Frequent reassessment is critical. Second, apply supplemental oxygen as prescribed and reassess response. Support oxygenation early, but evaluate effectiveness. Third, notify the healthcare provider of suspected early ARDS. Provider notification should occur once you recognize a pattern, not when the client crashes. Fourth, prepare for possible escalation to advanced respiratory support. This includes anticipating mechanical ventilation or high-level oxygen strategies. Preparation comes after recognition and notification, not before. Teaching point: ARDS is a progressive inflammatory lung injury. It starts with tachypnea. It progresses to distress. It ends in respiratory failure if not recognized early. Crackles are late. Waiting for wheezing is incorrect. And clear breath sounds do not mean stable lungs. NCLEX alert. The exam expects you to recognize subtle deterioration, escalate before collapse, and act before lung sounds change. The key takeaway is this: ARDS starts silently. Strong nurses notice the early clues and respond in steps, not all at once. Keep that escalation mindset as we continue into the remaining procedures and diagnostics questions. Question 22. This is a drop-down closed question focused on tuberculosis diagnostic confirmation logic. Before touching the drop-downs, pause and ground yourself. This question is not asking which test suggests tuberculosis. It is asking which test proves it. Now let's walk through the scenario. A client is admitted with a chronic cough, weight loss, night sweats, and hemoptysis, with a recent history of close contact with someone diagnosed with tuberculosis. Multiple diagnostic tests are ordered, and the nurse must decide which result establishes a definitive diagnosis and which findings are supportive. This is where many NCLEX candidates get trapped. Statement 1. Diagnostic confirmation. The diagnosis of active pulmonary tuberculosis is confirmed when the nurse reviews results from a. Here, the correct selection is sputum culture. This is the only test that definitively confirms tuberculosis. Chest X-rays show abnormalities, but they are not specific. Tuberculin skin tests indicate exposure, not active disease. Acid-fast smears suggest mycobacteria, but they cannot identify the species. On the NCLEX, confirmation always requires organism identification. Statement 2. Why this test is confirmatory. This test is considered confirmatory because it. The correct completion is identifies Mycobacterium tuberculosis through culture and isolation. This is critical. Culture not only proves the organism is present, but also allows drug susceptibility testing. That is what elevates this test from suspicious to definitive. Smears show acid-fast organisms. X-rays show damage, but culture names the bug. Statement 3. Role of other tests. Other diagnostic tests, such as chest X-ray and tuberculin skin testing, are used primarily to. The correct selection is support a presumptive diagnosis and guide further testing. These tests help raise suspicion and decide what comes next, but they do not confirm active disease on their own. They do not exclude TB. They do not confirm TB. They guide the workup. Teaching point. On the NCLEX, tests fall into clear categories. Screening tests suggest risk. Imaging shows damage. Smears suggest infection. Cultures confirm disease. If the question uses words like confirm, definitive, or proves, your answer must involve identification of the organism. NCLEX alert. Chest X-ray is the most common wrong answer. AFB smear is the most tempting wrong answer. Neither confirms tuberculosis. The key takeaway is this. Tuberculosis is diagnosed by the organism itself, not by exposure, imaging, or suspicion. Keep that diagnostic hierarchy in mind as we move into the final procedures and diagnostics questions. Question 23. This is a highlight the text question focused on cue recognition for pulmonary embolism. Before looking for the highlight, slow down. Highlight the text questions are not about guessing keywords. They are about identifying the single most meaningful clinical cue inside a longer narrative. Now let's read the scenario together. A nurse is assessing a client admitted to the emergency department with sudden onset respiratory symptoms. The client reports feeling anxious and restless and states, "I was sitting at home when I suddenly developed sharp chest pain that started abruptly, and I feel short of breath. My heart feels like it's racing." On assessment, the nurse notes tachycardia, mild cyanosis, and an increased respiratory rate. Pause here. This scenario contains multiple abnormal findings. Your job is to determine which symptom is most commonly reported first by clients with a pulmonary embolism. Now, look carefully at the client's own words. The correct text to highlight is sharp chest pain that started abruptly. That is the defining cue. Here's why this matters. The most common initial symptom of pulmonary embolism is sudden onset chest pain, often pleuritic in nature. This pain occurs when blood flow is abruptly blocked in the pulmonary circulation and the pleura becomes irritated. Dyspnea is extremely common in pulmonary embolism, but it typically follows or accompanies the chest pain. Other findings, anxiety, tachycardia, restlessness, and cyanosis, support the diagnosis, but they are secondary signs, not the most commonly reported first symptom. NCLEX teaching point. When the question asks for most commonly reported, the exam wants the classic presentation, not every possible finding. Pulmonary embolism announces itself suddenly. That sudden change is your clue. NCLEX alert. Do not get distracted by autonomic symptoms like anxiety or flushing. Do not overfocus on restrictive wording like only with deep breathing. Timing matters. Sudden chest pain first, breathing difficulty follows. The key takeaway is this. In pulmonary embolism, pain comes first. Recognize it early, and you recognize the diagnosis early. Keep that cue recognition mindset as we move to the final diagnostics questions. Question 24. This is a 2 drop-down close question focused on correct use and evaluation of incentive spirometry. Before touching the drop-downs, pause. This question is not asking whether the nurse knows what incentive spirometry is. It is testing whether the nurse can evaluate technique and judge effectiveness. Now let's read the scenario together. A nurse is caring for a post-operative day 1 client following abdominal surgery. The client is receiving opioid analgesics and is at increased risk for atelectasis. During routine rounds, the nurse observes the client using an incentive spirometer and evaluates how well the intervention is working. Keep one concept in mind as you answer this. Incentive spirometry prevents alveolar collapse by reopening dependent lung areas, not by improving comfort or changing vital signs. Statement 1. Technique assessment. The nurse determines that the incentive spirometer is being used correctly when the client demonstrates. Here, the correct selection is slow, sustained inhalation to reach and hold the target volume. This is key. Incentive spirometry works through sustained maximal inspiration. The goal is slow lung expansion and brief breath holding, not speed or force. Fast inhalation, forceful blowing, or short, shallow breaths all defeat the purpose. If the client rushes the breath, the alveoli do not stay open long enough. Statement 2. Effectiveness evaluation. Now move to the second drop-down. Which finding best indicates that incentive spirometry is achieving its intended effect? The correct selection is improved inspiratory depth with clearer breath sounds in the lung bases. That tells you the lungs are reopening where atelectasis most commonly occurs. Pain relief, changes in respiratory rate, or improved CO2 elimination may happen for other reasons, especially analgesia. They do not prove improved lung expansion. Clearer breath sounds and deeper inspiration do. Teaching point. On the NCLEX, incentive spirometry questions test evaluation, not instruction. Anyone can tell a client to use the device. Strong nurses verify how it's used and what physiologic change results. NCLEX alert. Atelectasis affects the lung bases first, so improvement should be heard and felt there. Numbers changing is not enough. Lung expansion is the goal. The key takeaway is this. Incentive spirometry works when inhalation is slow, sustained, and effective enough to reopen the lung bases. Technique first, physiology second. As we wrap up this respiratory procedures and diagnostics section, take a moment to reflect on what you've practiced here. Carry these frameworks with you, not just these answers. Now let's move into Section 3, Respiratory Pharmacology. This section focuses on one of the most high-yield areas on the NCLEX, how respiratory medications work, how they are prioritized, and how nurses monitor for safety. In this section, You'll work through 7 exam-focused questions designed to test medication purpose, not just names, correct sequencing of inhaled therapies, expected versus dangerous side effects, critical safety alerts that require immediate action, and common NCLEX traps related to respiratory drugs. Question 25. This is a multiple-choice pharmacology question focused on client teaching for expectorants, specifically guaifenesin. Before looking at the options, pause and anchor yourself. This question is not about side effects. It's about how the medication actually works. Now, let's read the scenario as written. A client with a productive cough is prescribed guaifenesin to assist with secretion clearance. During discharge teaching, the nurse evaluates the client's understanding of how to take this medication safely and effectively. The question asks, which statement by the client indicates correct understanding of guaifenesin administration? Now, let's walk through the options. Option A. If I develop a fever, I should take an extra dose of the medication. Option B. I should take this medication only with meals to avoid stomach upset. Option C. I will increase my fluid intake while taking this medication. Option D. I should decrease my daily fluid intake to prevent congestion. The correct answer is option C. I will increase my fluid intake while taking this medication. Here's why this fits. Guaifenesin is an expectorant. It works by thinning respiratory secretions, reducing their viscosity, and making them easier to cough up. That effect only works if there is enough fluid in the body to loosen those secretions. Without adequate hydration, the medication cannot do its job effectively. Now let's quickly eliminate the other options. Taking extra doses when symptoms worsen is unsafe. If fever develops, the client should contact the healthcare provider, not self-increase medication. The medication does not need to be taken only with meals. That wording should immediately raise a red flag on the NCLEX. Decreasing fluid intake would actually thicken secretions and worsen congestion, the opposite of what we want. NCLEX teaching point. Whenever you see expectorants, think medication plus hydration. If fluids are restricted, the drug loses effectiveness. NCLEX alert. The exam often tests medications by mechanism, not memorization. If the drug thins secretions, ask yourself, what supports that action? The key takeaway is this: expectorants do not work alone. They work best when paired with adequate fluid intake. Keep that principle in mind as we move into the next respiratory pharmacology question. Question 26. This is an order response question focused on naloxone administration, emergency preparedness, and nursing priority actions. Before jumping into the sequence, pause. Naloxone questions are never just about giving a medication. They are about airway safety before, during, and after reversal. Now, let's read the scenario as written. A nurse is preparing to administer intravenous naloxone to a client admitted with a suspected opioid overdose. The client is minimally responsive with shallow respirations. Before giving the medication, the nurse plans care to ensure safe reversal of opioid effects and to manage potential complications. You are asked to place the nursing actions in the correct order of priority. Remember this rule for the NCLEX. Assessment first, preparation next, medication third, monitoring last. Now, let's apply that framework. The correct first action is assess respiratory rate, oxygen saturation, and level of consciousness. Naloxone is given to reverse respiratory depression. You must know the client's baseline respiratory and neurologic status before administering it. Second, ensure resuscitation equipment is available at the bedside. This step is critical. Naloxone can cause abrupt reversal, acute withdrawal, vomiting, agitation, or recurrent respiratory depression. If the airway collapses or respirations worsen, the nurse must be ready to act immediately. Third, administer naloxone intravenously as prescribed. Only after assessment and preparation does the nurse give the medication. Fourth and last, monitor the client for improvement or return of respiratory depression. Naloxone has a shorter duration of action than many opioids. Once it wears off, respiratory depression can return. Continuous monitoring is essential. Here's the teaching logic. Naloxone does not cure an overdose. It temporarily reverses opioid effects. That means the nurse's responsibility does not end after the injection. On the NCLEX, monitoring after naloxone is non-negotiable. NCLEX alert. Never give naloxone without airway equipment ready. Never assume one dose is enough. And never skip reassessment. While the nurse's instinct is to administer right after assess, the NCLEX prioritizes ensuring that resuscitation equipment, like a bag valve mask or suction, is at the bedside first to manage potential complications of rapid reversal, such as projectile vomiting or sudden respiratory collapse. Only once the patient is assessed and the safety net is in place should the naloxone be administered, followed by continuous monitoring to catch a return of respiratory depression as the medication wears off. The ABC versus ADPIE conflict. You might be thinking, but breathing is a priority, ABCs. You are correct. However, ensure resuscitation equipment is available is actually an airway/breathing intervention. By having the equipment ready, you are ensuring you can maintain the airway if the medication causes a complication. The key takeaway is this: never perform an intervention that could destabilize a patient, like rapid opioid reversal, until you have the tools to handle the potential fallout. Naloxone may wake the client, but it is the nurse who protects the airway. Keep that safety mindset as we continue through the remaining respiratory pharmacology questions. Question 27. This is a highlight the text question focused on recognizing a life-threatening medication reaction, specifically anaphylaxis related to omalizumab. Before choosing what to highlight, pause. Highlight the text questions are not about finding any abnormal symptom. They are about identifying the one cue that signals immediate danger. Now let's read the scenario together. A client with moderate to severe allergic asthma has just received the first dose of omalizumab. While monitoring the client after administration, the nurse asks the client about any new symptoms. The client states, "I feel a little nauseated and my head hurts, but what worries me is that my lips feel swollen and my tongue feels thick." Stop there. This statement includes both mild side effects and a red flag cue. Your job is to highlight the finding that requires immediate nursing intervention. The correct text to highlight is, "My lips feel swollen and my tongue feels thick." Here's why this matters. Omalizumab is a monoclonal antibody used for long-term asthma control. One of its most dangerous adverse effects is anaphylaxis, especially with initial doses. Swelling of the lips and tongue indicates angioedema, which can rapidly progress to airway obstruction. This is not discomfort. This is an airway emergency. Headache and nausea are uncomfortable, but not life-threatening. They do not compromise breathing. Airway swelling does. NCLEX teaching point. When medications are involved, the exam wants you to prioritize airway threats first, not symptom severity or how worried the client sounds. If the lips, tongue, or throat are involved, you act immediately. Do not wait for hypotension. Do not wait for wheezing. Do not wait for oxygen levels to drop. NCLEX alert. Anaphylaxis is diagnosed clinically. You do not wait for labs or vital sign collapse. Recognition saves lives. The key takeaway is this. When the airway starts to swell, time becomes critical. Identify it fast. Intervene faster. Keep that airway first mindset as we move to the final respiratory pharmacology question. Question 28. This is a drop-down close question focused on inhaled medication sequencing logic. Before selecting any drop-downs, pause. This question is not testing whether you recognize drug names. It is testing whether you understand why medication order matters. Now let's read the scenario as written. A nurse is preparing to administer 2 inhaled medications by metered dose inhaler for a client with asthma, salmeterol and beclomethasone dipropionate. Both medications are scheduled to be given at the same time. That phrase, at the same time, is your cue. On the NCLEX, that almost always means sequence is being tested. Statement 1. Medication sequence. The nurse should administer blank first because it is a blank. The correct completion is salmeterol first because it is a bronchodilator. Salmeterol is a long-acting beta agonist. Its role is to relax bronchial smooth muscle and open the airways. Beclomethasone is an inhaled corticosteroid. Its job is to reduce airway inflammation, but it can only do that if it reaches deep lung tissue. Statement 2. Rationale for sequence. Now the second drop-down. Administering the bronchodilator first helps improve the effectiveness of the second medication by. The correct selection is opening the airways to allow deeper penetration of the corticosteroid. This is the core concept. Bronchodilators widen the airways. Steroids treat inflammation inside those airways. If the airway is narrowed, the steroid cannot reach its target. Teaching point. On the NCLEX, inhaler questions always follow this rule. Open first, treat inflammation second. Never alternate puffs. Never give the steroid first. And never assume same time means any order. NCLEX alert sequence questions are logic questions, not memorization questions. If the drug opens airways, it goes first. If it reduces inflammation, it follows. The key takeaway is this. Bronchodilator builds the road. Steroid uses it. Keep that sequencing rule locked in. It is tested often, and it is easy points when you know the logic. Let's move to the next question. Question 29. This is a matrix grid question focused on anti-tuberculosis medications and adverse effect identification. Let's read the scenario as it appears on the slide. A nurse is caring for several clients receiving anti-tubercular therapy. During routine assessment, multiple clients report new symptoms. The nurse must determine which medication is most likely associated with each adverse effect to guide monitoring and teaching. Now pause. Matrix questions are not asking you to guess. They are asking you to match signature adverse effects to specific medications. Each row must be evaluated independently. NGN task, matrix/grid. For each reported finding below, indicate whether it is most likely associated with the specified medication. Across the top of the matrix, you see isoniazid, ethambutol, rifabutin. Now let's go row by row. Row 1, peripheral numbness and tingling. Ask yourself, which anti-TB medication is known for nerve toxicity? The correct selection here is isoniazid. This finding is not associated with ethambutol, and it is not associated with rifabutin. Row 2. Difficulty distinguishing red from green. Pause here. This is a classic high-yield adverse effect. The correct selection is ethambutol. This finding does not belong to isoniazid, and it does not belong to rifabutin. Row 3. Flu-like symptoms and rash. Think systemic effects. The correct selection is rifabutin. This is not characteristic of isoniazid, and it is not characteristic of ethambutol. Row 4. Ocular pain or blurred vision. This is another critical safety cue. The correct selection is rifabutin. Ethambutol affects color discrimination. Rifabutin causes uveitis, leading to eye pain and blurred vision. Row 5. Low neutrophil count. Now think hematologic toxicity. The correct selection is rifabutin. Neither isoniazid nor ethambutol causes neutropenia. Let's lock in the patterns. Isoniazid affects nerves. Ethambutol affects vision, specifically red-green discrimination. Rifabutin affects blood counts and the eyes and causes flu-like symptoms. NCLEX memory hooks. Say them clearly. INH hits nerves. Ethambutol hits vision. Rifabutin hits blood and eyes. These drugs do not overlap on the exam. They announce themselves differently. NCLEX alert. Matrix questions reward pattern recognition, not memorization. Don't ask, what can this drug cause? Ask instead, what is this drug known for? Key takeaway. Correct identification of anti-tuberculosis adverse effects allows early intervention, prevents permanent injury, and improves adherence. Keep these signatures locked in as we move into question 30, the next respiratory pharmacology scenario. Question 30. This is a select all that apply question focused on hepatic monitoring for respiratory and anti-tuberculosis medications. Let's read the scenario exactly as presented. A nurse is reviewing medication orders for clients receiving respiratory and anti-tuberculosis medications known to affect hepatic function. The nurse plans appropriate laboratory monitoring to reduce the risk of medication-induced liver injury. Now read the question carefully. Which medications require baseline and ongoing monitoring of liver function tests? Select all that apply. Remember, for SATA questions, each option must stand on its own. There is no partial credit. Now let's read the answer options. Isoniazid, zafirlukast, rifabutin, albuterol, guaifenesin. Pause here and think. Which of these medications are known to stress the liver? The correct answers are isoniazid, zafirlukast, rifabutin. Let's break down why. Isoniazid is hepatotoxic. It can cause hepatitis and elevated liver enzymes, especially during the first 3 months of therapy. Baseline and ongoing liver function tests are required. Zafirlukast is a leukotriene receptor antagonist that is metabolized by the liver. It is used cautiously in clients with hepatic impairment and requires baseline and periodic liver enzyme monitoring. Rifabutin is an anti-tuberculosis medication that can also cause hepatitis. Liver function must be monitored throughout therapy. Now let's eliminate the incorrect options. Albuterol is a bronchodilator. It does not affect hepatic function and does not require liver monitoring. Guaifenesin is an expectorant. It does not cause hepatotoxicity and does not require routine liver enzyme testing. NCLEX memory hook. Lock this in. TB drugs and leukotrienes tax the liver. If it treats tuberculosis or blocks leukotrienes, your brain should immediately think liver labs. NCLEX alert. Do not select all respiratory medications automatically. The exam is testing risk, not drug category. If a medication can cause hepatitis, baseline liver function testing comes first. Key takeaway: monitor the liver for anti-tuberculosis medications and leukotriene receptor antagonists, not for routine bronchodilators or expectorants. Keep that safety-first mindset as we move into question 31, the final respiratory pharmacology scenario. Question 31. This is a bow tie question focused on clinical judgment and escalation after an adverse respiratory medication response. Let's read the clinical scenario as written. A client with asthma is receiving inhaled respiratory medications for symptom control. Shortly after medication administration, the client reports new symptoms. Assessment findings include audible wheezing, chest tightness, increased work of breathing, heart rate 112 per minute, oxygen saturation 91% on room air. The nurse must determine the cause, clinical significance, and priority actions. Pause here. This question is testing whether you can recognize when a medication is making breathing worse instead of better. Left side, likely cause. The question asks, which findings or medication effects most likely explain the client's current condition? Select 2. Now let's read the options. Paradoxical bronchospasm following inhaled therapy, expected beta-adrenergic stimulation from bronchodilator use, anxiety related to asthma diagnosis, delayed therapeutic response to inhaled corticosteroids. Pause and think. The correct left side selections are paradoxical bronchospasm following inhaled therapy, expected beta-adrenergic stimulation from bronchodilator use. Here's why. Paradoxical bronchospasm is a known, dangerous reaction to some inhaled medications, where airway narrowing worsens instead of improving. Beta-adrenergic bronchodilators can cause tachycardia and nervousness, which may worsen respiratory distress when combined with bronchospasm. Anxiety alone does not explain hypoxia and wheezing, and inhaled corticosteroids do not provide immediate relief. Center, clinical interpretation. The center of the bow tie is given acute, potentially life-threatening, adverse respiratory medication reaction. Lock that phrase in. On the NCLEX, worsening respiratory status after treatment is never normal. Right side, priority nursing actions. Now the question asks, which actions should the nurse take immediately? Select 2. Let's read the options. Stop the offending medication and maintain airway patency. Administer supplemental oxygen and closely monitor oxygenation. Document the event and continue to observe. Reassure the client that symptoms will resolve spontaneously. Pause. The correct right side selections are stop the offending medication and maintain airway patency, administer supplemental oxygen, and closely monitor oxygenation. Here's the logic. When breathing worsens after medication, you stop the trigger, you support the airway, you correct hypoxia, documentation comes later. Reassurance without action is unsafe. Teaching point. Some inhaled medications can paradoxically worsen bronchospasm. When that happens, This becomes a respiratory emergency, not a side effect to tolerate. On the NCLEX, worsening wheezing after treatment means escalate immediately. NCLEX memory hook. If breathing worsens after treatment, stop and support immediately. Key takeaway: medication responses can be unpredictable. The nurse's role is to recognize danger early and act decisively. That brings us to the end of Section 3, Respiratory Pharmacology, and the completion of the Respiratory Disorders and Medications NGN Q&A series. Across this chapter, you practiced how the NCLEX expects you to think: recognizing early respiratory deterioration, interpreting procedures and diagnostic data correctly, linking medications to mechanism, risk, and safety, and escalating care when breathing is threatened. Remember this: in respiratory nursing, airway and gas exchange always come first. Medications can help or harm depending on how you assess the response. Carry these frameworks forward. They apply across every system, not just the lungs. This is NCLEX-Review-Pro. Stay clinical, stay deliberate, and keep building exam day confidence.